Good afternoon. I'm Seung-min Han from Korea. I'd like to thank you for the NTN company and also appreciate Professor Ho to moderate this session. I know what time is it now? About 2:30 p.m. I know this time is probably the hardest time for you to stay awake. But I promise to make this session worth your time. Today, I'd like to introduce bright tissue level implants briefly. Probably many of you are still unfamiliar with this product. So I'm going to explore the clinical indications where they can be particularly useful. I'll spend the first half of the session covering the theoretical background, and then I'll present related clinical cases in the later half. Bright tissue level implant cases introduced earlier sessions, so I'll make it brief. Conceptually, bright tissue level implant can be understood as a structurally solid implant body without an internal hollow screw chamber combined with external hex connection at the coronal portion. By relocating the connection upward and eliminating the internal cavity, overall fracture resistance is greatly improved. It looks like a one-body implant featuring an external hex connection structure at the top. The greatest strength of the bright tissue level implant is simple, narrow but strong. This product was developed to enable even 3.5 millimeter diameter implants to function effectively when it is placed in the posterior region. These products have a unique design. Conventional internal conical connection systems, such as Superline, has a typically tapered design with a thicker coronal portion. In contrast, bright tissue level implant has a slight different configuration. Rather than being thickest at the top, its mid-body portion is relatively reinforced. This structural difference leads to a different pattern of primary stability during implant placement. With Superline conical connection systems, the highest insertion torque is usually achieved at the implant platform level. This means the maximum primary stability is obtained at the crestal bone level. On the other hand, with bright tissue level implant, primary stability is mainly achieved in the mid-body portion within the cancellous bone. Clinically, this difference becomes significant, especially in narrow ridges. When primary stability is concentrated at the crestal bone, as in a tapered conical system, stress may be generated at the crestal bone level. In contrast, when primary stability is achieved more centrally within the cancellous bone, stress at the crestal bone can be reduced. This may contribute to better bone preservation, especially in thin ridge conditions. Furthermore, thanks to the concave transmucosal part design, better soft tissue response is commonly found. Where are bright tissue level implants truly indicated? Before moving forward, let me begin by introducing two important concepts: critical bone dimension and individual alveolar phenotype. Critical bone dimension refers to the minimum amount of bone thickness required to maintain long-term implant health and stability. This concept is especially relevant to the buccal bone. This concept is known to have been first introduced by Dr. Spray in the year 2000. As is well recognized, it has been suggested that at least 1.8 millimeter buccal bone thickness is required around the implant. However, this conclusion was based on the observation that when 1.8 millimeter buccal bone was present at the time of implant placement, no implant thread exposure was noted at the time of uncovering second stage surgery. It was not derived from long-term functional outcomes after years of implant loading. In recent years, the concept of critical bone dimension has been more systematically investigated and refined. Dr. Monye from Spain proposed 1.5 millimeter as the threshold for critical bone dimension. This proposal was based on animal studies demonstrating that when buccal bone thickness at the time of implant placement was 1.5 millimeter or less, buccal bone resorption occurred. This was interpreted as a physiologic bone remodeling associated with avascular necrosis. In contrast, when the buccal bone thickness exceeded 1.5 millimeter, buccal bone resorption was minimized. Furthermore, even after ligature-induced periimplantitis was initiated, pathologic bone loss was significantly reduced. Based on these findings, he defined the critical bone dimension as 1.5 millimeter. The concept of critical bone dimension is now widely accepted and having been endorsed at the 7th ITI Consensus Conference. However, in clinical situations, implants are often found to survive even when buccal bone is partially or completely absent. For example, in a long-term randomized controlled trial comparing early and late and delayed implant placement protocol, Dr. Sharp evaluated the fate of buccal bone using CT scans after 10 years. The buccal bone level was found to be located on average 2.1 millimeter apical to the implanted shoulder. This indicates that implants were functioning with the exposed thread on the buccal aspect in the long term. Accordingly, some systematic reviews have suggested that critical bone dimension is not necessarily a determining factor for implant survival. So which perspective do you agree with? Is it better to have buccal bone, or is it acceptable even in its absence? In this regard, I would like to introduce an interesting study. This is a human study conducted from the University of Zurich in Switzerland. In cases where small dehiscence defect, one group received no additional treatment and was allowed to heal spontaneously, while the other group underwent GBR surgery to regenerate the lost buccal bone. The enrolled patients were subsequently followed and multiple clinical parameters were assessed. The initial outcome after 18 months demonstrated that even in clinical situations where dehiscence or fenestration was left untreated, there was not a higher rate of implant failure in comparison to a defect treated with GBR. Other clinical parameters in the spontaneous healing group were within acceptable limits. However, more favorable bone conditions were found in the GBR group. In the subsequent long-term follow-up at 7.5 years, the results were similar. The implant survival rate was 100%, no biological and the severe biological complications were observed, and the clinical parameters remained within acceptable limits. Nevertheless, bone-related parameters were clearly more favorable and remained superior in the GBR group throughout the observation period. Okay, while 7.5-year follow-up is not negligible, it may still be insufficient considering that periimplantitis is typically a late-onset complication. In fact, in the previous study, Dr. Jung published this study in cases where small dehiscence defects were left untreated. Further buccal bone loss occurred in 42% of cases compared to 20% in the GBR group, almost double the rate. These findings indicate that exposure of implant threads may represent a risk factor for the development of periimplantitis. The conclusion of the consensus report from Osteology Foundation was clear. It does not seem reasonable to leave exposed thread without further treatment. Moreover, performing lateral bone augmentation aside with exposed implant thread appears to contribute to the maintenance of implant health. For example, Dr. Bezic reported that periimplantitis developed in 13.4% of cases where bone augmentation was performed at exposed implant surface, whereas the incidence increased to 24.8% when no treatment was provided, almost double the rate. Therefore, the presence of bone may not be critical for implant survival, but it may be critical for long-term biological stability. So, if you're the patient receiving implant treatment, what would you prefer? If your implant thread were exposed, would you feel comfortable leaving them untreated? So if you agree that maintaining the critical bone dimension is important, bone augmentation becomes necessary. Now the next question is, to what extent can we augment? Consensus reports generally agree that horizontal bone gain of approximately 3 to 4 millimeter can be achieved predictably. However, I believe that rather than focusing on absolute numbers, we should consider this from a relative perspective. And this is where the concept of individual alveolar bone phenotype becomes highly relevant. This concept itself is not new. It appears that the term was formally introduced by Dr. Kurinen in 2023. In simple terms, each individual possesses a unique bone dimension, and it is biologically difficult to augment beyond these inherent anatomical boundaries. I have been interested in this concept quite a long time ago. As early as 21 years ago, Dr. Yang published findings related to this issue. He performed block bone grafting in the maxillary anterior region and followed the volumetric changes over five years. Interestingly, regardless of the degree of over-augmentation, the augmented bone volume eventually reduced to a level comparable to the patient's original bone envelope. More recently, Professor Song from Korea reported similar findings. He performed lateral bone augmentation using GBR procedure in chronic defect model of dog. Although overgrafted space beyond the original bone envelope were radiographically maintained, these areas did not contain newly formed bone. Instead, they consisted mainly of residual collagen membrane and bone graft material. He concluded that the bone defects tend to be restored to the original ridge contour by new bone tissue. Nowadays, similar studies can be easily found, and from these studies, you can see bone augmentation tends to remodel toward the patient's inherent alveolar phenotype. Now, we have discussed both the concept of critical bone dimension and individual alveolar bone phenotype. Let us integrate these two ideas. Around an implant, a certain thickness of bone is always required. However, when a defect is present, the amount of bone we can regenerate is limited to the patient's inherent biological envelope. Therefore, if a defect occurs in patients having thick alveolar phenotype, placing an implant with simultaneous GBR may still allow us to achieve sufficient critical bone dimension, even a wide diameter implant was used. What happens when a patient has a thin alveolar phenotype? In such cases, no matter how much bone augmentation is performed, it is difficult to maintain an optimal critical bone dimension around an implant, right? In such cases, a bright tissue level implant could represent a biologically favorable alternative. By using a bright tissue level implant, we can limit the amount of augmentation to the extent permitted by the patient's inherent phenotype while still maintaining the critical bone dimension. Okay, having discussed the biological principles, let us now examine how these concepts apply in actual clinical cases. This case involves the need for implants in the right central and lateral incisor sites due to the bridge restoration failure. The CT scan shows that the bone width of this patient is inherently narrow. As you can see from the central incisor site CT image, this is taken before tooth extraction. The patient's native bone thickness is not substantial. In the lateral incisor site, the ridge has already become significantly reduced. In cases like this, even with GBR combined with placement of a standard diameter implant, the potential for increasing the horizontal bone thickness is biologically limited. Consequently, securing a sufficient critical bone dimension may be difficult. Furthermore, in this case, central incisor site has a significant apical lesion as well as a bone undercut, making immediate placement somewhat risky. So, 2.5 millimeter diameter right tissue level implant was placed in the narrow bone of lateral incisor site, and ARP procedure without placing an implant in the central incisor site was performed. In this case, collagenated bone and collagen matrix was used. Open wound healing was intended as in a standard ARP procedure, and provisional restoration was provided using a remaining natural dentition. Although there was a minor flat sloping, healing progressed well without any noticeable complications. As is often the case, rigid resorption was observed despite ARP procedure. Based only on the 3-month CT outcome, some bone formation was observed, suggesting that implant placement may be feasible. There is still insufficient buccal bone around the implant placed in the lateral incisor site. However, clinically, a completely different situation was found. There was no bone formation at all. I'm not sure of the exact reason, but this may suggest that ARP procedure per se may have limited effectiveness. Anyway, I had intended to take a simple approach via ARP, but the unexpected outcome complicated the whole situation. So definite solution is required to resolve this problem. Considering the patient's inherently thin alveolar bone phenotype, 3 millimeter diameter of right tissue level implant was selected instead of standard diameter implant. Nearly whole thread was exposed. It was protruded out of bony envelope, so meticulous GBL surgery should be followed. Bone graft material, a mixture of small amount of autogenous bone and osteoin xeno and allograft material was applied. And then this bone graft material was applied up to the lateral incisor site with a thin buccal bone, and membrane was placed like this slide. This is collagen membrane 2. Collagen membrane 2 was fixed at the apical portion using fixation pin and stretched to the palatal side and placed around the transmucosal part of this right tissue level implant. And remnant piece of collagen membrane 2 was placed to cover the lateral incisor side. And wound stability was achieved in this way, and primary flap closure was achieved. This is healing. Healing was uneventful, and second stage surgery was performed after 4 months without raising a flap at the crestal area. Only small vertical incision was made to remove the fixation pin. Finally, provisional restoration at both implants were connected, and provisional restoration was modified several times to accommodate patients' preferences. And this is final outcome. Take a closer look at the CT image. Compare with the previous CT image taken after 3 months, just after ARP procedure, 3 months after ARP procedure, sorry. The difference is obvious. It clearly appears that bone has formed. Please note that the regenerated bone seems to extend only up to the patient's inherent biological boundary. The key point here is, by placing 3 millimeter diameter of right tissue level implant, I was able to maintain the critical bone dimension. If a standard diameter implant had been placed instead, this would likely not have been possible. And this is 1 year follow-up. Critical bone dimension is still there. In this case, lateral incisor missing site shows severe bone atrophy. A superline 3.6 millimeter narrow diameter implant was barely placed in this site, but bone dehiscence occurred. Nearly all the threads were exposed. So, as routinely, a simultaneous GBL surgery was performed meticulously. Membrane was stabilized with both membrane fixation technique and membrane holding suture technique. Healing was uneventful without any complication during healing period. 4 months later, when I opened the play, I was disappointed at the result of this surgery. Although substantial bone formation was found at the middle area and at the apical site, bone gain at the implant platform level was somewhat deficient despite meticulous GBR. The CT outcome after 5 years shows that the buccal bone thickness may still be insufficient to be considered as an optimal critical bone dimension. Achieving further horizontal bone augmentation in this inherent thin phenotype would have been difficult. If a bright tissue level implant with a smaller diameter, such as 2.5 or 3 millimeter, had been selected, a greater critical bone dimension might have been secured. Let us consider another clinical cases. In this mandibular posterior side, advanced ridge resorption has already taken place, leading to a markedly reduced bone width. By evaluating the intact first premolar lesion on the right slide, lower right slide, we can appreciate that the patient's native alveolar bone thickness is relatively thin. This slide shows the surgical procedures. If I had planned to place wide diameter implant in the molar lesion and the standard diameter implant in the premolar lesion, a staged approach surgery would likely have been a more appropriate treatment option. However, in this case, by placing 4 millimeter bright tissue level implant in the molar lesion and a 3.5 millimeter diameter bright tissue level implant in the premolar lesion, I was able to perform simultaneous GBR and implant placement. For GBR surgery, tenting screw was used and membrane was fixed using the screw because the mandibular bone has so rigid and so hard. And mixture of bone graft material, composite bone graft material consisting of osteogenesis collagen and autogenous bone was applied. Healing was uneventful. I intentionally buried these 2 tissue level implants to promote better wound healing. I believe that submerged healing with primary closure results in more favorable bone regenerative outcomes than open wound healing, especially in compromised cases. And re-entry surgery was performed after 4 months. Previously exposed thread was covered by newborn tissue completely, and horizontal bone thickness increased much, but to the level of adjacent bone site. Anyway, final zirconia processes were delivered, and this is the CT outcome. I was able to perform simultaneous approach. I was able to keep the critical bone dimension in this case. In clinical practice, we encounter indications for relatively narrow bright tissue level implants more often than you might expect. This is another case of bridge failure. When I reviewed the initial radiographs, I also felt that this would not be an easy case. Moreover, patients strongly requested implant placement in all 4 anterior sites. On the panoramic radiograph, you can confirm a large size of incisive canal between the central incisors. The size of canal further limited the available bone in this area. Therefore, I explained to the patient 4 unit bridge restoration using 2 implant placement in both lateral incisor sites might be feasible option. The central incisor site could be more challenging, but patients still wanted to have 4 implants. So I first proceeded with bone augmentation surgery using GBR approach. A titanium plate was placed using 3 screws. Titanium plate was placed like a fence. It looks like a shell technique. And some space was created between the placed titanium plate and native bone. In that created space, a mixture, composite bone graft was applied. Composite bone graft also consists of a small amount of autogenous bone and allograft and osteogenesis particulated bone. And collagen membrane was placed like this. This is collagen membrane too. This membrane has a stretched stretchable. So memory was fixed at the apical site using just one screw and stretched to the palatal site and stabilized further using suture material. And another collagen membrane one was placed for further protection. Wound stability was achieved like these slides. And flap was closed, and healing was uneventful during the 9 months of healing period. Although the CT image suggested adequate overall bone thickness, insufficient bone is still observed around the incised canal. The real situation was as follows. Proper positioning of standard diameter implant might be inevitably limited by the location of incised canal. Shifting the implant further vocally or distally was not an option because that would compromise aesthetic outcome. At that moment, a bright tissue level implant was a viable option to me. So 2.5 millimeter bright tissue level implant were placed without encroaching upon the incisive canal while maintaining the proper alignment with mandibular dentition and keeping the adequate buccal bone thickness. Ultimately, 3.6 millimeter diameter superline 2 implants were placed in both lateral incisor site, while 2.5 millimeter bright tissue level implants were placed in 2 central incisor sites. The lower slide shows the situation at the time of second stage surgery, healing or connection surgery. A stable bone formation can still be observed around the implant. Provisional restoration was delivered. Through the provisional restoration period, final prosthesis was delivered, reflecting patient's wish. All the prosthetic procedures proceeded with digital process as shown in the earlier session. And this is final CT outcome. I know this is not ideal, but fully acceptable to the patient. It will be interesting to observe these cases that I presented today in the long term by comparing the bone response of bone level implant and tissue level implant. Okay, I'm gonna have to skip the rest of the lecture. Here is my conclusion. Implant design have steadily evolved toward improved performance. Moving forward, they must continue to evolve in a direction that resolves the limitation of existing implants. Preferably, it should encompass not only improving strength, but also reducing surgical burden, and more importantly, preserving biology. The bright tissue level concept reflects this direction. While long-term data will further validate this performance, a bright tissue level implant provides the biomechanical solution for cases where strength and reduced surgical invasiveness must coexist. Keeping the critical bone dimension or reducing the mechanical complication, both can be achieved with bright tissue level implant. Thanks for your listening, my lecture.